Dr. Dalal, I can assure you that this lady will again buy over-the-counter herbs.
So she did, I saw her 2 weeks ago, and she brought a list of like vitamins and supplements that she wanted to take.
Yeah, I'm sure. She will.
Yeah.
So we're ready for the questions. So I'd like to invite the speakers to come on stage.
So my question to the panel. So if you have a case like this, where you have what looks like an acute liver injury, drugs versus autoimmune, and you find a lot of fibrosis, would that speak in favor of autoimmune? I mean, this lady, in hindsight, maybe she has drug-induced, in hindsight. But if you find a lot of fibrosis on liver biopsy in this setting, would you favor autoimmune, or would you favor drug?
Usually it's very difficult to establish diagnosis at this stage to provide, our colleagues in pathology, they tell us it's very, very difficult to give a solid diagnosis on this acute stage. They might say it's, as I mentioned, drug-mediated AIH, or it's DILI, but it's very difficult to tell it is a de novo AIH, which is already having hepatitis, which is now an active phase. So what I'm going to do, I will start to treat her with steroids, as I mentioned, and if she was showing a good response, I will try to withdraw and see, as drug-mediated AIH, you can withdraw steroids. I mean, they can maintain response without steroids better than if it's de novo AIH. So I'm not sure if we can tell in that stage if it is a drug-induced or a true AIH.
Biopsy gives you that little bit more insight because, sometimes we look at the patterns of fibrosis, which may suggest that there's some underlying disease there, which has been there for a while. And, would that fit more with an autoimmune process? And then with the DILI, maybe on top of that. So, in these types of presentations, exactly like this case, we would always make a very strong case to the patient that we should be biopsying, because we want to get as much information as we possibly can. If we're going to be thinking about transplanting the patient, we want to know as much detail as we can, and that's an obvious way of doing that.
My question is for Dr. Dalal. So as you correctly said, that one of the crucial steps in someone presenting with acute hepatitis to identify a reversible cause that can be treatable. So when would you consider rebiopsying in a patient that all the workup was negative and he's obviously not in acute liver failure but still has persistent severe transaminitis?
If the patient is presenting with a more hepatocellular pattern, is if they don't get reduced by 50% in 30 to 60 days is when I would consider biopsying them. But in terms of a patient presenting with a cholestatic picture, you kind of have more time. So I think the general consensus is about 6 months. If they don't improve, then you would biopsy them at that point.
I have two questions for Dr. Munira and Dr. Mann. For Dr. Munira, you asked a question regarding if we know any other score for the liver. I think there was a score, the liver risk score, that was published in 2024, and they found that it has slightly specificity rather than the FIB4. Do you know about it, or the liver risk score?
Liver score?
Liver risk score, yeah. It's an English-based.
And what is it based on? Is it like, I'm not aware of the score. Is it like a...
Just like the FIB4 plus...
Simple blood markers?
Yeah.
Okay. No, I'm not aware of it. Are you aware of the liver risk score? Liver score. No, I'm not aware.
And another question for Dr. Mann. Do you recommend for cirrhotic patients, obese, BMI more than 40, sleeve gastrostomy? No.
Shaib, yes, I do recommend, especially in well-compensated child A, no sign of portal hypertension. I have a couple of patients I did recommend. They went for bariatric, they did very well. Now they well-compensated, even their liver parameter, liver enzymes, beautiful. So I do recommend in certain circumstances.
Perfect. I think we are short of time. If we have only one question. Thank you.
Good morning. Thank you, Dr. Dalal, for the nice presentation. I know DILI is always difficult to deal with, but in case of patient presenting with ALF and DILI, we all know that the use of steroid is slightly controversial. Now, do you have any demographics that would help you choose which patient would you start with, steroids or not, considering that the infection rate in those patients are really scary? So what would your take would be?
So where I trained, the advantage I had is our center had very quick, it was a transplant center. So we tended not to start steroids on acute liver failure patients because we had good access to transplant. And we know that these patients, if we have quick access to transplant, it's better not to start steroids and go ahead with the transplant because they have less complications, infections, things like that. So it depends on the resources that you have. If you have access to transplant, I would hesitate to start the steroids if I can transplant the patient. But if you don't have access to transplant, these are the patients that you would kind of go through the case in detail and see if they have any contraindications to starting steroids first. Because most of the time, these patients are going to have acute kidney injury, they're going to be septic or develop sepsis. So it's a very case-by-case situation, but in general, if you have access to transplant, I would not start steroids and focus on getting the patient to a transplant. But if you don't, you can consider if you really don't have any contraindications and the autoimmune is your main kind of differential, the patient fits, has the risk factors and the kind of the socio-demographic factors for autoimmune hepatitis. So I would consider that in that scenario alone.
One comment and one question. I will not ask 10. Patrick, very important things you mentioned about eradication of hepatitis B. Our goals in WHO, we have to reduce our threshold. We were always looking for 2 out of 3, FibroScan F2, raised liver enzymes or PCR more than 2,000. But nowadays, overweight, diabetic, family history of HCC. We have to expand diabetic, hypertensive, and all these things. This is very important. The second point, in the old days, I used to, maybe in 2003 and 4, when Pegasus and Pegintron started, we used to do the HBS antigen level, and we used to do the hepatitis B genotype. If there is any role in the future to go back to the HBS antigen level, especially in immune tolerant patient, so we can, if the HBS antigen level is high, so you need to treat that patient. Are we going back to the genotype and HBS antigen level? And the use of Pegasus?
So they're really, really important questions, and you're absolutely, I mean, all of these new drugs in chronic hepatitis B as the functional cure program are actually, they're being defined by the levels of surface antigen. So we're quantifying surface antigen. So we see patients with relatively low level surface antigen, less than 1,000 IU. These patients do better. Patients with surface antigen levels greater than 3,000, these patients tend to do worse. So surface antigen is a mainstay now of management of chronic hepatitis B. I completely agree with you about comorbidities, obesity, essential hypertension, metabolic risk factors that we heard about earlier. I recently published a meta-analysis showing that in those patients, we're much better off intervening much earlier along the lines of what the WHO and all the other guidelines are moving towards. So the barriers to treatment are being removed. If I was a physician with a patient in front of me, I would want to ask myself, well, why am I not giving this patient an antiviral in chronic hepatitis B? These are very safe, highly effective drugs, and they do what they're supposed to do. They're very, very good drugs, and we know there's real benefits to them. And the final part of your question around pegylated interferon, you'll have seen at the last, I would say, couple of international meetings, INT'L, ASLD. Interferon is really the only immunomodulator that we have available that's being used in combination with the antisense oligonucleotides, the siRNAs, because checkpoint inhibitors, you know, these drugs can be highly toxic, very dangerous. The jury's out on therapeutic vaccination, and the TLR agonist field really hasn't done it at this point. So pegylated interferon is going to be there for the short term, definitely. Genotype, no, because the antisense and the siRNAs will take all genotypes. So genotype is still, I think, at the back of the queue.
Thank you very much for all the speakers and the moderators. We'll move on for our next session.